I am sorting out some logistics in the background to make sure that we're also live streaming. And I think we are right now also live streaming on YouTube. Really happy to see you all. Good morning, good afternoon, good evening for those of you. We're having a wonderful TBPPM webinar today on Monday, 22nd. Glad to see that we have fantastic attendance, and we also have great speakers lined up. We have one speaker who will give a presentation, and then Madhu will be moderating the Q&A. So for everyone who's joining, please use the Q&A button if you have any questions for our panel members. Know that you have a chat where you can introduce yourself or say a few things, but use the Q&A for questions, please. That's our best way to handle the question and answer session. You will hear more from all our speakers. All the information is also on our website. Please view the website if you also want to have access to the recording or the presentation afterwards. Everything will be saved on the TBPPM website. And while we're also live streaming on YouTube, you can forward that to colleagues. I will put that in the chat in a little while. So with that, I am really pleased to hand over the microphone to Dr. Madhu Kapai, who will be introducing our speaker, and then from then on take over the moderation of today's session. We're talking about diagnostics and the universal access to rapid TB diagnostics, which is a really important area. I'm very excited to hear about it. Madhu, it's yours.
Wonderful. Thanks everyone for joining. It's great to see almost 60 people from around the world join us today. Just last month, WHO released first ever diagnostic standards. I put a link to the document in the chat box. And Dr. Nazir Ismail led the effort in the WHO TB department, the diagnostics division. And it is really important that all of us, the TB community, try and understand the new standard and figure out how best we can apply it in our regional and local context, including the private health sector that many of us are also dealing with. The overarching framework and all of that, Nazir will explain to us in a second. But for me, it's very simple. In 2023, can we do better than smear microscopy for people with TB? Can we do better than empirical therapy where there isn't even a testing done, no microbiological testing? How could we justify that when the world has done billions of PCR for COVID, right? We've just gone through the emergency phase of the pandemic. We've done billions of PCR tests, and yet for people with TB, we're not able to do better than a microscope with no drug resistance testing, with all its limitations. This just cannot go on. And I'm delighted that WHO has put out a strong standard that, encouraging all of us to migrate to better tests that we have today. But it is up to us as a community to get behind that standard and make sure it gets done so that everybody benefits from universal WRD access and universal DST. So the first speaker would be Dr. Nazir Ismail from WHO, who led this effort. He will walk us through the standard and its component, its metrics, and then we can ask him a few questions. And then we have panelists from very different walks of life, NTP, TB survivor, private provider, PPM, intermediaries, so that we get their reactions on how the standard will apply to them. Over to you, Nazir. Thank you.
Thanks a lot, Madhu. Good morning, good afternoon, good evening to everyone, and great to be here. As Madhu indicated, I'll be speaking about the recently released WHO standard. Let me just get my slides up. Hopefully you can see that in full screen.
You can see it clearly, Nazir. Go ahead.
Excellent. Right. So that's the title. So I think just to quote what you've seen in your meeting invite, right, from a recent paper by Madhu and his friends. So diagnostics are a key component of any TB strategy, and they've highlighted if we cannot find TB, we cannot treat TB, and if we cannot treat TB, we cannot end TB. So really, if you just think about it carefully and sit back, obviously diagnostics plays a key role in sort of starting this cascade of care. What's important, as has been highlighted as well, is that it's not just about diagnosing TB, but ensuring that you can get rapid and early diagnosis, and that diagnosis can also detect drug resistance. And why this is important is really to identify and select effective regimens. I think empiric treatment is assuming that you have susceptible TB, but that cannot be wholly true anymore. Having said that, when you look at the diagnostic space for TB, unlike probably a decade ago where we had microscopy and expert had just started, there's a multitude of different technologies that are out there right now, but uptake has been really slow. And lastly, as Madhu has highlighted, I think COVID has taught us, has obviously negatively impacted where we are with the TB epidemic, but has taught us important lessons of what can be achieved. So looking briefly at the diagnostic gaps, when you look at the entire cascade from the percentage of people estimated to those that are notified, 40% of cases are not detected. Even of those that are notified, only 38% as of 2021 had a rapid diagnostic as the initial test, whereas the target was for all cases. And then looking at even just among the notified cases, only 63% were bacteriologically confirmed. And of those that were bacteriologically confirmed, 70% were tested for rifampicin resistant TB. And going further down that cascade, of the rifampicin resistant TB cases, only half got fluoroquinolone DST. And if you go further down, for bedaquiline and linezolid DST, that's much lower. So you can see there's a shattering of gaps at every step. And as you go, the numbers don't seem so bad, but you're actually losing at each step essentially. So there's definitely a key problem that we need to face up to as a reality. The underlying issue that we see as we've looked at the data, so we have one measurement looking at number of those that are tested with a WHO recommended rapid diagnostic as the initial test, and you see the graph on the left. The black line indicates that metric that we've been monitoring over years. And you can see it's gradually moving up, but not at the scale that needs to be. And the green line indicates number of TB diagnostic sites that have this technology available. So you can clearly see that, access is a fundamental issue. This is still a lab-based access, but we don't have any better measurement. But it's clear that after 10 years of introduction of these rapid molecular tests, we're still very far off from where we need to be. And secondly, is that if you look at on the picture on the right, I mean, it's not just expert anymore. There's a variety of tests like the TrueNat, LoopAmp, but a variety of other sort of more laboratory-based assays like Abbott, Cobas, BDMax. And these are the same platforms you've seen for COVID as well and for people living with HIV as well. So there's a menu of tests available, but yet we are quite far behind. So coming to the WHO standard, so this is the first that we've done in terms of setting a set of benchmarks and standards. And just to note that these standards are about access. So that's a key central focus. So the objectives of these standards are really about improving access to these rapid diagnostics. The second is really improving the bacteriological confirmation of TB diagnosis and drug-resistant TB. And the third is really to reduce the time to diagnosis. Classical turnaround time, but also early access, meaning bring diagnostics closer to where patients arrive. The standards, I went through an extensive consultative process, but it was based around 7 principles. The first was around the commitment behind these efforts to ensure access. The second was about equity. And you notice we've put an interpretation column in the document. And the equity here also includes equity within private and non-NTP sectors where patients should have access to these tests, which we've identified as a particular issue. The third is that patients should receive the most accurate and rapid test to diagnose TB. And this really becomes an important point around transition from smear microscopy, which is inferior to the current rapid tests. Patient-centric approaches. The coverage is quite important, covering all people with presumptive TB. Number 6 is about the timeliness, and number 7 around the capacity and actually optimization of the capacity to provide the access that's needed. So going specifically into the standard itself, we've decided to use a cascade of care framework, which is probably much more useful and sort of sees this thing as a holistic integration rather than a siloed piece. But this is very focused on diagnostics. So it starts off from those who are identified as presumptive TB, ending up with those that receive a diagnosis. And the 2 steps in between are accessing testing and being tested. And it kind of feels so obvious, but that you access a test and get tested, but we know that's not necessarily the reality, right? And also just to note that the standard is focused on all presumptive TB cases and includes people in the private or non-NTP sector. And we have specifically mapped out items that are relevant to the private sector, and I'll go through that just now. So looking at the 4 steps, essentially there's 4 steps of the cascade with 12 benchmarks, and this is the sum total of what the standard is about. The first standard about identifying presumptive TB is about contacts of TB and other high-risk groups being screened. And the second is about use of chest X-ray. So really improving our ability to detect TB or identify presumptive TB. Step 2 really is about access, and this really speaks to the algorithm that's in place. And then when we talk about access, there's one in terms of which facilities have access, and the focus is on primary healthcare and benchmark 4. And not only the health facility, but benchmark 5 is about the people, technically the people or the individual who can access that test, right? So it's facility and people. And then number 6 is the actual infrastructure to deliver on, or at least have the testing capacity to meet the need. Step 3 is around not just having access to the test, but making sure that these systems are in place in terms of quality assurance and monitoring that in terms of the error rates. Number 8 is about presumptive TB, and that's really a change in focus rather than notifications, but really dealing with those with presumed TB and across all sectors. And the 9th one is about focused on universal DST. And here I won't really go through the definition, but includes all the components of drug susceptibility testing for, as I mentioned, RUF for fluoroquinolones, bedaquiline and linezolid as a sort of minimum criteria. And then the last is around receiving a diagnosis that's around, focusing on pulmonary TB and ensuring that it's not just the result, but the patients actually benefit from that result and there's actual definitive diagnoses that are achieved. And 11 and 12 are around how optimally the services are delivered to make sure that all resources can maximize case detection and make sure more people get onto treatment. And number 12 is around the timeliness of that result, which we know is lacking in many parts of the world. So as I mentioned, I'm going to focus on this presentation looking at, this is the PPM group, so I'll really focus a lot around the public-private partnership components around the standard. So not going into all the other components, but I'll just touch on a few things. So if we look at step 1, there's 2 things that are of key interest. The first is that we know there's a lot of TB out there that's not detected. And the people that are highest risk for TB are those in high risk groups, like children under 5 particularly, but people living with HIV and a variety of other groups. And specifically looking at it from a private sector angle now, or non-NTP angle, we've expanded that now to also include minors, prisoners, and healthcare workers, which sort of straddle into these other domains, right, of high risk. That should also be factored in within the private sector components of healthcare. And then in terms of the second one, we haven't really focused on chest X-ray screening within the private sector. I think that is largely done, but for the public sector, it's an important issue. The next is step 2 around access to testing. So we know that a large proportion of people seek care with signs and symptoms of TB at primary healthcare level, right? Over 80% of people present at that level. Often we see that they end up reaching hospital levels, and those delays lead to increased morbidity and mortality. And looking at that specifically within the component of the non-NTP or private sector, here you'll see the specific metrics that I mentioned about use of access care models for the private sector, whether this is using private intermediary agencies or private laboratory engagement models, trying to minimize catastrophic costs for patients. That's sort of a key component. I've not put the numerators and denominators into this presentation. It's in the report itself. But just to highlight, for example, this one here focuses on the number of districts and number of districts in the country that have a model that incorporates the private sector to have access to these essential diagnostics. So that's one part of the access component. The second is around as I mentioned, the individuals that are being tested. And like I've mentioned, the trajectory has been very slow over time of those individuals that got this WHO recommended rapid diagnostic as an initial test. And within the private sector, you'll see we've asked now that this data now gets disaggregated. So we don't just get a country level data, but we actually look at what proportion of notifications from the private and from the NTP and non-NTP sectors, and what's the proportion in those. And the whole idea with the standard is not just sort of a once-off, but an annual monitoring to make sure that within countries, the metrics can be measured, monitored, and responded to. Moving on to step 3, this is around being tested. And here I'll just focus on the second and third one. So the second one speaks all about presumptive TB being tested with a rapid diagnostic. And we know there's a large proportion of individuals that are, that are, number one, are diagnosed bacteriologically, but by smear microscopy, right? So that's the first underlying challenge. When we look at the private sector on the right-hand side, it's not just smear microscopy, it's often no testing. And often because of underlying barriers related to cost of testing, etc. And that has been dealt with in the previous benchmark. But really, if you look at empiric treatment, is very common in the private sector. And this is really aiming at setting the benchmark for presumptive TB cases to be monitored and tested within the private sector as well. And this is also aimed at sort of minimizing the catastrophic cost related to such care in the private sector. And the other thing, so again, on the universal DST component, as I mentioned in the beginning slide, the gaps for drug susceptibility testing is quite serious. Not just rifampicin resistance, which we should theoretically have done much better at, but are still struggling, let alone fluoroquinolone and other resistances. And we look at the private sector, we don't really have formal reporting, and the idea now is to actually monitor the situation, because we know that patients don't exist in a nebulous space of private or non-private. We all live in one community, and therefore not sort of dealing with the universal DST principles need to also now apply in the private sector. So these are sort of equal access and equity for these sectors as such as well. Moving on to the last step of the universal of the standard. So I'll just focus on the first one here. I'm not dealing with timely delivery and positivity rates, but really just looking at pulmonary TB, right? And even if you look at, despite having access to tests, right, even though it's suboptimal, almost a third of all TB cases, pulmonary TB cases, do not even get a bacteriological confirmation, right? Often it's clinical and chest X-ray based, and this, as I mentioned, is particularly a key issue in the private sector. And having this further disaggregation, but also identifying areas of correction and response to address this chronic problem. Because I think if you look at a lot of countries, especially in Asia, where the number of bacteriological confirmed cases are much lower. Sometimes there's only half of cases are bacteriologically confirmed. We can see a lot of that is driven by private sector components as well, right? And this is really aiming at sort of disaggregating and sort of putting down the problem and getting the support required to move things forward. So having sort of mapped out those sort of standards and those 12 benchmarks and how they apply to the private sector particularly, we've also added in the report not just the benchmarks and the 12 items that need to be addressed, 6 of which are specific to the private and non-NTP sector. We've also added a component around how to go about and what are the key things, what are tangible items that can help address these or fix these gaps in these steps as such. So what we've done is obviously we have the guidelines, we have the handbook, and these are all on the knowledge sharing platform that's publicly available. And the infographic on the bottom right really is showing you the additional components we've put into the document. So we've done what we call a solutions mapping at the bottom, sort of looking at all the barriers and enablers and listing them and identifying what has shown to work. And then on the top, you can see implementation strategies in the country case studies. And we've provided 2 country case studies of how this has really worked. I'll just briefly touch on these here. So In summary, what was found from the systematic review of barriers and enablers was really this issue of equitable access is a huge issue, right? And that is across sectors. The second is the use of multi-component strategy. So not just putting an instrument, but making sure that the systems around that are all linked and almost a cascade of care can be delivered. The third is around communication, right? Making sure that people are knowledgeable and aware. And often we neglect that, but it's a very simple, low cost, high impact intervention. The next one is around multi-disease testing. So often, access is quite challenging and resource intensive initially. But when we look at the potential value of multi-disease testing, the platforms that are already existent, and looking at like COVID's instruments that are lying around not being used, right? Using multi-disease approaches is far more sustainable. There are a variety of comments around longitudinal models of care, not just doing things one-off, but consistently working with people and programs to improve things sustainably. The integration of sample referral networks was also a very strong thing, and also about not just patients moving between public and private, but trying to move samples rather than patients, right, between these different sectors and minimize the cost burden. Use of data and communication software in lab systems to ensure that things can be reported and resulted fairly quickly and reliably. And then again, the network, but not just once-off networking, but more holistic views of diagnostic network optimizations. And then lastly, around the resource mobilization and political commitment that comes underneath all of that. And just looking at from the stakeholder engagement, and I'm not going to go through the detail on the slides, but just looking at practical things, what worked, what didn't from country experiences. These are real world examples, right? Not just theoretical principles. It's surprising to see the first thing on this slide is solar panel, right? I mean, we know of electricity issues in many parts of the world, and sometimes just a simple solar panel that is supplied could sort out a huge issue in terms of access. What came up very clearly and strongly as well was the issue around market diversification. Again, this speaks to the private sector again, right? So I mean, it's really about getting more people and more companies into the markets, and we've created a pathway for WHO pre-qualification for TB diagnostics, and seeing more products coming through. So really, that is really aiming at addressing that issue. Simple things like refresher trainings using virtual, like very much like we're doing today. Working with incentives, the Nigerian example was quite fascinating to see how just some motivation to staff would maximally improve utilization and access. And then the last was an important point around integration between public and private. We've seen with COVID, I think it was very clear that movement of samples between these different sectors happened much more effectively and benefited patients at the end of the day, right? So this was quite clear. And I think there's value propositions that need to be negotiated and shared. And then just lastly, on the way forward in terms of how to sort of not just do the benchmarks, but how to move things forward. I think the Nigerian case study was quite fascinating, where it wasn't just, like I said, about the instrument, but they did a lot of community engagement, trainings, even just simply sticking an SOP onto an instrument, right? Because of the mobility of staff. It was all part of a package that made sure that services were delivered timely and effectively, and reach was maximized. And the Philippines case study was really around diagnostic networks. They've done a great job for TB. They started integrating with other diseases, and now have expanded to even start moving treatment around, right? So I think all these models of care show us that these initiatives could really make a difference in access beyond even diagnostics, but we need to start somewhere as such. And then the last thing, just to finish up, what we highlight in this document is around the investment case. Again, this is a business-focused way of thinking of diagnostics. It's very clear that TB diagnostics are a clear sort of your best money bet, right? Return on investment, even better than for HIV, hepatitis B, hypertension, and diabetes in low and middle income countries. It's very clear we've seen price reductions for TrueNet very recently. So this document came out before that announcement. But even with the HIV world in the viral load space, there has been price reductions, and I think as we expand markets, this will naturally occur and become more accessible in that respect. But we also make a point in the document around concessional pricing not to be limited to public sector or NGOs only, but really have models that expand this access to private sector. I think Mario has already highlighted the COVID Diagnostic Consortium and the amount of testing that's happened for COVID. And I mean, there's no excuse for TB. I mean, we're aiming to get currently around 10, 15 million tests per annum. I mean, and we're hoping to get to 30 million, which is sort of a drop in the ocean compared to what's been done for COVID. And I think it's definitely doable. And often there's fears about costs. But if you really sit down with the numbers, diagnostics for TB accounts for a very small fraction of the total cost, but yet it's so central to the overall services as such. So just to conclude, and hopefully that gives you a good summary of it, Madhu has already put the link in the chat for the full document and all the details are there. But the expectation is that adoption of this WHO standard with the 12 benchmarks will really improve the number of individuals getting an accurate and rapid diagnostic test, which I think is sort of a human right in some ways, right? If you have signs and symptoms of TB, you want the best upfront. And I mean, especially if you're going to a private sector, you should be getting best, right? Theoretically. The second, obviously, that we hope to achieve with this is really to get more bacteriologically confirmed TB cases. We know there's a lot of empiric treatment, and you look at the outcomes sometimes maybe worse because they might have other diseases that are being treated with TB medication, right, which is not correct. And the second is obviously bacteriologically confirmed TB cases represent the pool of infectious cases and are therefore a priority for testing. And then also, like I mentioned, the issue of resistance testing, but not just RIF, but universal DST and the quality assurance around that. We hope that through this effort and through upfront investments, I think there has been a push now with a variety of like Global Fund and others, but I don't think it's enough. A lot more needs to come forward, and I think private sector as well, to ensure that this will lead to universal health coverage, better health for all, and really, I mean, TB is a curable and preventable disease, and really makes no sense for us to be sitting where we are. And then lastly, I think the standard is not just about public sector, but includes the private sector as an integral whole. Each step of the cascade had one at least target or benchmark for the private sector. I haven't gone through the numerators and denominators. I don't need to go through that detail here. It's very clear what needs to be reported and what needs to be done to achieve what we need. So with that, hopefully I've kept within my time. A lot of this is available on the WHO website, and you can find it also the TB knowledge sharing platform. So I'll stop there. Thank you.
Thank you, Nazir. Brilliant job of summarizing a huge amount of information in a short period. We do appreciate that the standard does explicitly talk about the private health sector, and it has explicitly addressed some of the benchmarks, because all these years it's been frustrating for those of us working in PPM that just availability of diagnostics in the public sector will magically somehow be accessible to the private sector. And unless we think about it and work on it, it doesn't happen on its own. So we have a few questions for you, initial questions for you. There's a question from Elaine on all the DNO efforts that are happening in many parts of the world, all the lab optimization work and so on and so forth. How do you see it aligning with the standards and also this whole push for multi-disease testing and maximizing, global fund investments across various disease areas? Okay,
thanks a lot. So what you'll notice, I don't mention the word DNO or DNA in the first part of the standard. And I think the key difference is that for me, the standard and the benchmarks are outcomes, right? DNO is a process to achieve that outcome. So when we're talking of the outcome is primary healthcare access. Number of people, presumptive TB is being tested. So that's the outcome. And you'll notice in the second part of the document, DNO and DNA are quite integral. Multi-disease testing is quite important. So the solutions to achieve the outcome are definitely network optimizations. The challenge, I think, is that to do a DNO takes quite a lot of time and resources. And to be honest, the skills needed to do some of the DNOs can be fairly complex. And in my view, I think what is needed is not necessarily a full-fledged DNO, but I think just for a country to be able to quantify the number of primary healthcare facilities and the number that have access is the first start to a DNO, right? Which a country should know and immediately should be able to respond. They might not have a special software modeling, but at least they should be able to map themselves because they should have in-country knowledge of where things need to reach, at least rapidly. I mean, when I think of countries like South Africa, where we started, I mean, you have an idea of where your burden is. You start off and you start rolling out in your high burden districts, and then you optimize as you go along. But I mean, there's no need to wait for a special tool to come, right? You need to act now. That's my view. But I think they're fantastic and really an important solution to get us in. The one thing just to highlight as well, I think, is we often think of DNO on the public sector only usually and a single disease. So I think that the need to look at more broader sample transportation systems is important. And the second is, how do we look at the private sector and how do we integrate and leverage some of that? It's something I haven't seen being done, but probably needs further work, to be honest. Yeah.
Nazir, the next question is, there's a lot of staff turnover or a staff attrition in the private sector and these PPM work, and that tends to slow down the expansion of new diagnostics in the private sector. Do you have any, is that the standard provide any solutions for this particular kind of barrier?
So I think two things. When you're looking at these molecular tests, they're a lot more simpler than, I know people like microscopy, but a microscopy needs a trained microscopist, right? Expert or TrueNet is not as complex. It's a pipetting skill that is fairly universal in being able to train people. But for me, the most telling example was in Nigeria. So they faced a lot of challenges to get it going in their country, right? But I found it quite amazing that they stuck an SOP on the instrument, right? That was their solution, because there's always people that will move and a new person comes in. And again, they need to be trained, but you train them, they'll forget. But you have an SOP on the machine, it helps, right? And I think we can't get away from staff attrition. I mean, I'm surprised to hear about the private sector, because often the public sector says they all go to private, right? So I don't know from private where they're moving on to after that, but there's going to be this issue, and we just need to be more pragmatic. And I think for me, there's no limit to training, right? Because you actually enriching people's lives, right? So just continue training more people and put the SOP on the instrument. Yeah.
So Nazir, there's a good question from Amir from Pakistan that expert availability has been a big challenge for many countries. The supply chain challenges, procurement, and Cepheid being the sole distributor, he says they're unable to cope with the orders. Are there other manufacturers in the pipeline? And I think your standard does provide lots of options for people. Can you explain that?
Yes. So currently, we have 7 different manufacturers that are now recommended as rapid diagnostics. So Expert is one of them, and Cepheid's product, but TrueNet is one other. But then if you look at what I showed on the screen, we have what we call the moderate complexity assays. These are lab-based tests, but include the BDMAX, include Abbott, Roche. These are all recommended, and the performance of these tests for TB detection and for RIF and INH is really excellent. All right, so I think that's where we are today. But just to also highlight that we've opened sort of a pathway for WHO pre-qualification. So we know there's like a variety of other products that will be coming in fairly rapidly in the coming year, maybe maximum 2. What I gather, like Pioneer, SD Bio are quite forward. Tata has got a product. So I think there's a variety of products that are coming, and I think from a WHO perspective, we recommend what is best, and not necessarily a product as such. And just lastly, to finish off that point, in the past, we have sort of name branded our recommendations. So mention Expert, mention TrueNet, but going forward, we moved away, and we'll be addressing this last gap around Expert and TrueNet in the coming year. But it'll be sort of low complexity and moderate complexity assays. And the market would be open as such. Yeah.
Wonderful. Thank you, Nazir. This is an important question for all of us in PPM. What's the most effective way to involve independent private laboratories in the TB program? And I think the standard does mention some models there as well.
Yes, yes. So I think the private laboratories, I think um, in terms of what we've provided in the standard is to actually specify that the countries need to report on the number of districts and how many of those districts have a access care model. And the one option is either that samples get referred to the public sector, but the other model is to use private laboratories, right? But the limitation there is obviously to ensure that there's a market price cap with some sort of agreement. And I think I just lost the title for that.
IPACT, yeah, IPACT.
IPACT intervention, right? So it doesn't have to be IPACT necessarily, but that model is still acceptable as a way forward for engaging private laboratories.
In fact, we had an entire webinar only on private laboratories and how to engage with them. William Wells had a very interesting analysis done by USAID. Petra, if you can post a link to the video of that private laboratory webinar, that might be very helpful. We'll ask one more question from Guy before we go to the panel. And Guy's question is, 90% of the expert machines are probably deployed in public facilities, even in countries where most people go to the private sector. So how do we use that capacity that is existing in the public sector, but make it available for privately managed patients? So can we give those cartridges to private labs or help private labs from the public system? How do you make that? How do you use that resource in the public?
So Guy is right. I mean, it's one thing is that a large proportion of that experts are in the public sector, but also a large proportion have a level of underutilization, substantial amount in some aspects. So I think this, when you're thinking from a business mindset, right, it provides a business opportunity for the public sector to engage the private sector, right? I mean, the public sector is not really money driven, but essentially they need money, right? Like any health system. And I think selling of services is also an important opportunity, right? That you have this capacity, private sector could, purchase services, which I think has worked, I think, in India as well. It's been one model. So I think those kinds of opportunities need to be explored, right? I mean, you've invested and you should sort of make sure the investment is fully utilized.
Absolutely. So it was interesting that your standard makes the case that we've been making for many, many years, that the concessional prices should also be available to the private sector, and that TrueNAT price announcement drop was one of the first documents where I saw something that would be available even to the private health sector. So I'd like to understand that better and see what that actually means. But we have learned that even if you make the concessional prices available to the private sector, there has to be some kind of price capping. Otherwise, it all goes into the profits of the private laboratories. And I think every country pretty much had to do price capping around COVID PCR, because that's how countries managed to put a kind of a lid on the crazy price gouging. And there's a mechanism there, I think, that all countries can use. Yeah, I think it's I mean, it's done in even like where there's pay for fee services within public sectors as well, right? I mean, even within the private sector, the insurance scheme will cap a certain price. So I think that principle is well established, and I think and it's important to protect patients. I think that's the important part, right? So for me, I see what you just said is something that we definitely support. And I think, like you said, in the end, we need that $4-5 molecular rapid test. That's when we really will see traction. So we need to continue to innovate, and then also find, maybe all the leftover capacity of COVID PCR, find ways to use some low cost, open source PCR type thing that can run on multiple different systems that are already now existing in the pandemic. Yeah, I think that, what you said is very true, but the underlying challenge to get to those price points is often the hesitancy to be bold and to expand testing, right? Because people see this market and it's only for expert. That's the perception, right? But our demand is probably twice or maybe even triple or even 4 times what we need, right? And once people see that and there's an investment towards that, then prices will naturally go with market forces, right? So I think we just need to realize that, I mean, I think take a patient-sided view on one hand, that all patients need the most accurate test as part of the principles and the most rapid test. On the other hand is, I think with the market forces, we should see price reductions that's sustainable
I mean, it'll reach a plateau point, right? Where people can't go below a certain price, and that would be the price, right? Unless there's a breakthrough in technology again.
Thank you, Nazir. There are a few more questions for you in the Q&A box. If you wouldn't mind answering them quickly, that will be wonderful. Okay. Quite a few people are worried from around the world on availability of expert cartridges or even TrueNAT machines. So supply chain, I think, continues to be a massive problem that we need to be thinking harder about how to solve for countries. So that's an important consideration as well. All right, now I want to kind of turn to our panelists. We had a TB survivor who was supposed to speak first. Petra, Zolelva hasn't been able to join us. Is Fumeza there on the call? Can we elevate her to a panelist? Petra?
Madhu, sorry, I think Fumeza left. Also, Busisiwe was here. But I've asked if there's anyone who's willing to speak from the community or affected voice, let me know. I will pull you into the panel.
All right. But I want to kind of begin with the NTP perspective. And it's wonderful to see Dr. Mathur here from India's National TB Elimination Program. Dr. Mathur, I saw in your TB India 2023 report, which just came out, you have a beautiful new algorithm which starts off with CBNAT as your #1 test, initial test for TB. So you already are there. You're already thinking about how to roll out molecular testing. What is the barrier in India scaling it up? What is your biggest obstacles? Where do you need support from the community?
Madhu, there is no barrier kind of a thing because we are still, in the process of procuring more and more such machines. And in fact, we have just submitted a proposal a few days back to the ministry to get more and more, molecular diagnostic machines. In fact, we have an aim to saturate all the blocks. The blocks, when I say blocks, we means the TUs here, and the population of TU or a block here is around 0.2 million, 2 lakhs. So we have an ambitious program to saturate all the blocks, and we are in the process of it. In fact, we have in our country more than 5,000, to be very precise, 5,090 such machines, such platforms available. And we are in the process of enhancing the numbers so that we should be able to provide an excellent accessibility in terms of providing this test to all our patients, or rather to all our presumptive cases also.
That's amazing to know. And I was really happy to see your algorithm in the most recent TB report. How does that factor in the fact that more than 50% of India's TB patients initially seek care in the private health sector? What is your strategy for making WRDs also accessible to people in the private and the informal sectors in India?
You are right, Madhu. More than 50% of our patients, they go to the private sector and they take care, in fact, from any disease from the private sector. So our strategy right now is that we are involving the private providers through PPSAs. We have different models right now existing in the country, but the most prevalent is the PPSA model, that is the private provider supply agency. So we have an agency, interface agency, which connects the provider, the patient, and the government also in a way. So such kind of agencies are working in around 300 districts right now. And we are looking forward to have more and more such kind of interface agencies in the country. And in fact, many states have sought assistance in their PIPs. PIPs are annual submission, annual proposal, through which the states seek support from the central government in terms of funds for a particular activity. So we have provided assistance to all the states, and in the near future we may have more such agencies, interface agencies, which will provide such kind of a link to a private provider with the agency and then to the government. So we are quite hopeful that in the future we will have more and more private patients also linking to the government services. Government services, when I say, it includes the diagnostic services as well as the treatment services.
As well as the FDCs, the free FDC program.
Yes.
Excellent. Excellent. Thank you, Dr. Mathur. So India, unlike many countries, is lucky to have its own indigenous NAT. And I believe there is now many more NATs, indigenous NATs, because of the COVID pandemic and all the effort to scale up COVID PCR. So how do you hope to use all of the indigenously made products to reach your targets for making universal access to WRDs?
Yeah, in fact, we are heavily banking on our indigenous, manufacturers now, because initially we used to have only one vendor or manufacturer. Now we have at least three indigenous Make in India manufacturers, which are ready to supply us these NAT machines. And we are looking forward to have more and more such indigenous machines. In fact, I have just told you that we have submitted a proposal in this regard. So we are looking forward to the indigenous or Make in India kind of machines and the consumables.
That's wonderful to know, Dr. Mathur. Thank you so much for your input. I want to move on to Erlina from the perspective of a private provider, a doctor, a physician who's seeing people in the front lines. Erlina, when I visited you in Jakarta, you showed me your very, very busy hospital system. So how is Indonesia handling WRD access? Is it available easily in your country to people in public and private sector? If not, how do you plan to, how will providers in Indonesia access the WRD as per the standard?
Okay, thank you, Madhu. So as I always say that I'm a double agent. I work at the public sector in the morning and the private sector in the afternoon. So I know the difference. As everyone saying here, that 2/3 of TB patient go to private sector, private provider. But a very problematic thing is that the rapid test now is delivered majority in the public sector. And then many of people say that or blaming the private provider by saying not effective diagnosis, low notification, low treatment success and everything. So instead of blaming them, I think we need to support them, facilitate them with these rapid diagnostic facilities, support and facilitate with the effective drug facility also. And majority of the private sector still using the conventional tests such as acid-fast bacilli. It will take 2 or 3 days, while a rapid test only takes a few hours or 1 day at the most. So I mean, if this rapid test also can be accessed by the private provider, meaning that they can identify quickly those TB cases, and meaning also the limit the window of effective TB patient in spreading the disease, and also give a good opportunity for the rapid treatment and prevent the complications such as empyema or maybe also the destroyed lung problem and everything. So please support this private provider. In my country, Indonesia, there are efforts in involving this private provider. There is a project TBPS, TB private sector, supported by USAID and also collaborate with a professional organization, the Coalition of Professional Organization Against TB or COPI-TB. We are together trying to involve this big chain private hospital for DOTS strategy, and also giving access for this rapid test. But it just started this year. So, I mean, we still need to see the result, whether this really worked or not. But my point is that rapid test is really, really good to, I mean, as Nazir Ismail said, that to treat TB, you have to find TB in order to towards TB elimination. And to find TB, you have to be quick, because we have only 7 years to go. And you know, like in my country, Indonesia, there is a 969,000 new cases every day that we need to find. So rapid test is the solution. But sometimes we have challenge, as I mentioned, accessibility of this rapid test in private sector, but also now sometime in some places the cartridge is also short out, and then I don't know, my country is working hard on that. But for my conclusion or my suggestions that is, please support the private provider to have a good access for this rapid test and also for the treatment. And if you want to place this rapid test, PCR test in the private sector or private lab, please WHO approach the company or the pharmaceutical company to reduce the price, as is what happened in COVID. In COVID, all the private laboratory can do PCR test. Yes, in the beginning it's a high price, but then reduced to the accessible price. I think it's happened everywhere. And by having this collaboration with this effort for everyone, we can control COVID. And I think we can control TB as well by having this collaboration, equity, intervention, and using this innovation. Well, we have expert, we have TrueNet, and maybe next time we have this tongue swab and everything. So I really what do you call it? Support the rapid test.
Thank you.
Not only the public by private, please.
Thank you. I love your passion. You definitely want to see all people with TB, public or private sector, get the best WRDs that we have today. We almost need a slogan, WRDs for all, right? Just like we want to scale up the shorter regimens as well. Adil, you are at the front lines in Mercy Corps, which is like a huge organization that deals with a lot of PPM projects on the ground. How have you made WRDs accessible to private providers and patients in your projects, and what are the biggest barriers you're facing?
Yeah, in Pakistan, I think the situation is not very much different, as Arlena mentioned. Most of the patients, they are accessing the private sector for their treatment, particularly for tuberculosis. If you see the total case notification last year, around 40 to 50% notification is from the private sector. But the issue of expert testing, particularly, which is the main WRD in Pakistan, the issue is same. When we started expanding our expert testing network in Pakistan, public sector was the first choice. So most of the machines, they were installed in the public sector sites. And with the passage of time, when private sector start expanding, our reliance on public sector increased. The solution that we at that time thought is transporting sputum samples from private GPs and private laboratories to the expert sites in the public sector. This has solved to some extent, but then there were certain challenges. The main challenge is the timings of the public sector. Public sector operates from early in the morning till afternoon or noon, and private sector is also available in the evening. And that's one of the reasons most of the people, they prefer to go to private sector after their duty hours or job hours. So that's a challenge. And because of that challenge, when we see the throughput of all the public sector sites, it's just around 20% to 30%. So they are not working optimally. With this, lesson learned, we started expanding private sector expert testing sites, and now Masigor, which is present in 120 districts across the country, working with 14,000 private practitioners. We have just 28 expert sites, and these expert sites are running at their full throughput. So the lesson learned is that it's not the solution that the expert site is available, but equal contribution in the public and private sector is important. So this way we are working on that, and recently conducting DNO exercises, as someone has mentioned. We found that we need around 100 more machines in the private sector, and we are in the process of procurement, mainly through the support from Global Fund. So this way we are increasing our access to the gene expert sites in private sector. Interestingly, with the advent of with the availability of expert sites in expert testing or in our country, we found that the reliance of general practitioners is increasing more and more on WRD, which is expert test, as I mentioned, and their reliance on microscopy has reduced. So it has a detrimental effect in a way that most of the practitioners, they are now asking patients to get screened through X-rays and then diagnosing them on the basis of X-ray finding, instead of even sending them to sputum microscopy, which is freely available all over the districts where we are working. So this has reduced to our positivity rate, and we are stuck at a positivity rate of about 40%, and we are trying our hard to increase that positivity rate. And we think that with the increased network of gene expert sites in the private sector, we definitely see increased positivity rate, and that is evident from the sites where we have expert machines, and all the presumptive are being tested on those expert machines. There the positivity rate is around 50%. So that's our approach now, and we are working with National TB Control Program, who's leading us, that more and more private sites will be established. And in our country, as per the DNO recommendations, after every 30 kilometers, there should be expert site, whether public or private, and at least one expert site in each district for private sector should be established. And in the areas where there are no private sector sites, we'll link the public sector sites through our sputum transport mechanism, which is now functional in 75 districts. So that's the approach. Thank you.
Thank you, Adil. It's very impressive to understand how much effort you're putting in to scale up access to WRDs within your PPM programs. I think for all of us working in PPM, we celebrate the success of increased notifications, but we don't ask the questions, are those really people with TB or not? Have they been bacteriologically confirmed or not? So I think the next wave for all of us would be to not be satisfied with just notifications, but to make sure notifications mean good diagnosis, good treatment follow-up. So in short, quality of care also needs to increase along with notifications. And I think WRD is an important index of quality of care, right? If you're not even testing someone for TB correctly with the best tools, then that's a big, big quality gap. So Nazir, thank you for the wonderful work that WHO has done and for explicitly addressing the big, big private health sector that we are all worried about. And for all of you, NTP, private providers, PPM organizations, let's please get behind the standards and implement it, because there's already a campaign to roll out all the short course regimens now for DRTB, the 6-month all oral. None of that is going to happen unless diagnosis improves, right? How do you put someone on a 6-month treatment if you don't even know they have resistant TB? So one thing blocks the other. So all the excitement about short regimens will go nowhere unless we get the diagnostic part right. And that's why I think I see them both as a pair, right? We can't do one without the other. The best treatments will be useless if we don't get our WRD for all right. So let's push WRDs for all as an important campaign, even as the UNHLM is coming up in September, because that's the rock bottom that we should be doing for people with TB. And in 2023, just to mess around with smears is simply unacceptable as quality of care. So deeply appreciative of all your work. Back to you, Petra.
Thank you all. Thank you so much for a super interesting webinar. And Nazir, thank you for the presentation. To all panel members, wonderful input and excellent commentary points for us to think about. Madhu, thank you for your excellent moderating as always. I'm going to quickly launch a poll for those that want to maybe give us some feedback, which would be really helpful. I'm wishing everyone a wonderful rest of the day. The PowerPoint presentation from Nazir, a report, and all the discussions that we had will be available on our website. I will make sure to share it also on our Twitter. So please look out for this. You will get a news response if you're part of the TBPPM Learning Network, which you can please join us. You will receive a news message on any of the outcomes of this webinar, and we will help promote and advocate the WRDs because this is really the way forward. Thanks to everyone. Looking forward to seeing you next time. Bye-bye.
Thanks, everyone. Bye.
Thank you very much.
Bye.
Thank
Bye.
you. Bye-bye.
Bye-bye.
Good to see you, everyone. Thank you so much for joining. And please feel free to join us, tbppm.org. You will find all the information, and we will be sending out new webinar information soon. And there's lots more that we can collaborate together. Wishing you all a good day. Bye-bye. Thank you.